Good morning. My name's Bob Hanley. I'm a T&O surgeon in Oxford, and I'm very grateful for being asked here. Now, I'm not going to make it as complicated because that's not my way. I've been the old bloke sat at the back of the room for the last week looking at all the fancy stuff that you've been being taught. But I work on a simple basis because it's straightforward. So get it right the first time. And what am I trying to do? I've got a fracture, I'm trying to get to a healed bone. And what route am I going to take to get there? And so Alex showed what he thought about the fracture healing process. And I drew this because my daughter, who's a primary school teacher, said if you can't teach primary school kids, you're never going to be able to teach people who are a bit more grown up. And so there's a normal route through that. There's a delayed route. There's a route where it's trying to heal, but something's stopping it. And then it's just totally bloody lost at the bottom, and it's a pseudarthrosis. And in my simple mind, that sort of fits with what's going on. When I see a patient, they more or less will fall into one of those groups. So this bit, I'm supposed to be talking about how internal fixation affects this normal process. So we'll talk about the other routes on there a little later on. So the normal process, and you'd think it was quite straightforward, but it's not. There's another component to put in there. It's not just I've got a fracture and I want it to heal. Where do I want to get to now? There's more to it. So I want not just a healed bone. There's more to it than the healed bone. I want a living patient, because I don't want to kill them in the process of doing it. I need to have a plan for their mobilization, a plan for their weight bearing, and much more beside. So I'm working in a context of a real person. And that's important for us to remember. It's not just a biological or a mechanical process in isolation. So we've been looking over each other's shoulders about what everyone's been preparing, and there's real similarities between all of our preparations. So there is duplication, and I'll skim over it, but it helps you to see that we are thinking on the same wavelength. And so I had this concept that you will all have been taught when you're doing about fracture healing, that there can be direct bone healing, where if you can get appropriate low strain, appropriate stability, then it's as if the bone was never broken in the first place and it just remodels, or you get this indirect bone healing with the bone healing organ that Alex has described earlier on. So those are the two ways in which we feel the body is going to react to the fracture which is there, and how do we make one of those work. So you've had the yield tolerances. Now, I don't like the word principle. As was said to us just now, you should be prepared to change what you're doing. So principle is a bad thing because inherently it means that you're never going to change your mind on it. So most things you talk about are concepts, and you should be prepared to have different ones when you come next year, if that's what's happened. But I would be really upset if this lot changed, because so much of what my thinking has been about with fractures relates to this, that if you have the right mechanical environment, then certain tissues will form. So it's a concept, but it would be a disturbing one if it was changed. So what is stability? So stability, the general definition of it is it's a tendency to resist change. So it's not absolute. It can't be quite like that. So, am I in a stable relationship? Yeah, sure I am. Yes, yeah, my wife thinks I'm in a stable relationship, but could I be tempted eventually? Well, the stability isn't infinite, and the same goes with there. So there are ranges, there are spectra, but we've divided those into two, and we've used terms which do imply that it's very specific. So we use absolute stability and relative stability just as the words, but as was shown, it's a continuum. So what do we mean by absolute stability? At the fracture site, there is low strain. So you've got a low enough strain, or hopefully the appropriate strain for bone to remodel. If we're dealing with the fracture as surgeons, we want that to be maintained until there's fracture union. So it's not just that there's stability, but there needs to be durability. The two need to go together. And if we are going to achieve that absolute stability, that low strain environment with a fresh fracture, we need to preload the fracture site. That's a prerequisite of it. There's energy stored within the system, and you preload the fracture site. Relative stability, at the fracture site, there's initially the potential for higher strain. But as has been, Alex showed us, dinosaurs knew how to heal their bone, and what you're presuming is that the body is going to respond in a way that progressively it lowers the strain at that site until it comes to a point where ossification can properly occur. So there's a potential for higher strain initially, but you hope you've not disturbed the environment so much that it can't go through its natural progression, get to the point where it produces a low strain environment and it ossifies. And there is no preloading at the fracture site initially. So what about preload? Alex admitted that he stole slides from David Elliott, and I've done just the same. So preloading. Preloading is where you store potential energy for the benefit of a construct that you've made in terms of what we're doing. So you've stored potential energy. So these are nice bits of asparagus, and if you want to hold them in a stable bunch and do it with something where you can't store much potential energy, like, for instance, a bit of string, if you tie it tight enough to hold them together, you do a lot of damage. But if you shake them and they rearrange, then they tend to become loose again. If, on the other hand, you use, as we got on the other side, well, it's not moving, elastic, there's an elastic band around there. As you shake it, it moves to a position of greater stability. The band will lose some of its elasticity, shake it more, greater stability, and as long as you're within the elastic limits, it will keep achieving greater stability. You've preloaded it. And that's an important concept in not just fracture fixation, but in mechanics and buildings in general. And I might show you a slide at the end, which showed I learned something from just recently. So how do we preload a fracture site? We've seen this. These are Stefan Perrin's pictures. First course I ever went on with AO, Stefan Perrin was lecturing, and he used this, he did it at a live demonstration. 2 bits of polarized glass and with perspex bone showed how you can get, as you compress with that lag screw, you get those stress lines within the construct, and you can see that they're compressing at the fracture line. There is energy stored in there, and implicit in that is if there's compression at the fracture line, there's something else which is stretching. There's elasticity stored in there. You're either compressing around the screw head, you're stretching the screw slightly, and you can imagine what's going on in there mechanically. And you can do that with plates as well. So you can look at this. Unfortunately, the plate isn't made of perspex, so you don't see the stress lines in that. But if you look at that and see where those stress lines are, that's a straight plate, and somebody demonstrated this with a frame earlier on, how if you wanted to compress things, you slightly off-center it. And you see at the bottom, where the plate has been tightened, there isn't very much compression. If you pre-bend the plate, so up here, you can see there's a little gap between the plate and the notional bone. As you tighten that down, there's stress lines all across the bone. It's compressed. And moreover, the excursion that you've got in that plate, the bend that you've taken out of that plate, because if you undid those screws at the bottom, the plate would spring back up again. It's stored energy in a spring. You've got preload on there, and because there's a good amount of stored energy in there, it can be maintained for the duration of the fixation. So you could get direct bone healing with an appropriately put together construct. Preload doesn't depend on the tools that you're using. It depends on how you're using them. So you can put screws in to get relative or absolute stability. You can use a plate to get either. You can use a nail to get either, because they're away. So you can use pretty much any sort of device to preload if you want to. So you need to think when you're doing, am I preloading this or not? Now, this is where the complication comes in, because we're not operating on a bit of plastic bone, we're operating on a person. So when you're thinking about how you're going to approach to get the environment you want for fracture healing, first thing to think is, who the hell is it I'm operating on? What are they like? I'll show you some examples of patients in a bit, but what's the environment into which it's going, and what are their needs? Because this patient, if you're operating on their lower limb, you need to be able to say, I'm going to allow you to fully weight bear and mobilize. Whereas if it was one of you younger members of the audience, I could say to you, don't put your weight on it for 3 months, go around with crutches, and you might do it, you might not, but you have a choice. So you need to know the environment in which you're putting it, because the durability of your construct will be important. Then you need to look at the fracture types or fracture patterns, because there are options that you have. So you know that with the simple fracture patterns, you can, if you wanted to, if you felt it was appropriate, use direct compression. But with the more complex ones that you get where there's fragmentation, then you're going to be using a bridging technique. And finally, where is it on the bone? So what loads are it likely to be put over it? So people will talk about shear, and you can get shear from axial loading or rotation. So if you think about where you fix in the body, if you fix a forearm fracture and radioulnar joints are functional, it's very difficult to get rotational loads on them. You have to be quite extreme to do that. And so you don't need much strength in that configuration to resist the rotation. Whereas if you fix a humerus, particularly more proximally, the rotational loads on that are extreme. And so if you put something like a nail in the humerus, they're much more prone to go onto non-unions than it would be if it was in a bone which is primarily axially loaded, such as the tibia. So you need to think where you're putting it. So it's the patient, the pattern, and where is it? So let's just look at a couple of examples. So the patient. This was done in a weightlifting competition. A woman bench pressing 160 kilos, and it broke. Fortunately, it was in a competition, and she had the people there to catch it. So she was a healthy subject. That was true. You can see by the size of the cortices on there that her bone is pretty good. So you're going to be able to do something with that. If you put just a plate on there, you're not going to be able to support the rotational loads on it adequately. So with that configuration of an oblique pattern, you can lag it and plate it, and you've got two planes crossing the fracture, and you can support that rotation, and you can maintain a good reduction, and you think, because of a good bone, store the energy in it, direct bone healing. If that was a more transverse pattern, you wouldn't be able to put a lag screw through it. And so to get control on that, another plane of control, it's now quite common, and I would favour it to put an extra little plate on there, orthogonal to the one, your main plate on it. It gives you more control over the rotation than you can get with an eccentrically placed plate. And so with a transverse fracture, difficult to lag, but you can put a second plate. Think where your plates are going to go if you want durability. So if I look at that fracture, I look at that and I'd like to think I think about the person first of all, and I think about that in a minute, but I look at that and I'm already thinking, I could plate that, and I know I could put a plate on there, and if I put one screw in that good bone there, with a plate appropriately placed, one screw could hold the lot on. Good cortical bone, nicely down, making an apex for it, and it's going to get good durability. What happened was that the plate was put on the medial side, so the screws that are in the good bone in the diaphysis are doing remarkably little. And all the screws that are doing the work are lower down, and they're working in their most unfavourable condition. It's trying to pull them out. And so fairly inevitably, it just fell to bits quite quickly. So if you go back to that picture initially, you think, I can fix that, that's easy to do. I can put a lag screw through it, that's easy to do. But if I want to protect it to give it durability, I'm going to put the plate on the side which is using the best bone, which is a diaphyseal bone, and the plate is pushing using those best holds. So you can think that through. And in good bone, you can do that, and that can be nice and successful. Different circumstance. So this is you can see the fragmentation there. This is a younger person. So you can see there's a little wedge fragment there. And are we going to go for direct bone healing? No, it's not necessary. Can we fix that in a way where we'll get secondary bone healing? Yeah, sure. And you can do that very neatly. This was a young teenager, and so that plate's not in the bone at that point. That's outside, contouring it on the outside, and then you slide it down, measure where you are, cut the screws top and bottom, and it goes on and it heals beautifully, and she manages very nicely, and you feel, done a good job. Similar bone, oh, hold on, yes, similar bone. I don't have all the original x-rays for this, but this one, so there's if you see the fracture just there, and the configuration that was put on, so it's below, you can see it's below a total hip, and nice long plate. They've approximated with a couple of lag screws, doing what they might do. But this is in a large man. He's a good bit bigger than me. He's in his 70s, and he needs to weight bear. That's the only way he's going to get around. So that looks as good as the other one, but there isn't the durability in the system because he's heavier. And so that thing about the initial construct is good, but you need, will it stand what you want to put it through? And it broke. And so this is where you can combine implants if you want. You have a different approach. And this is what I would do initially for this patient now, is to gain another method of control on there so you can, with a good degree of confidence, allow them to fully weight bear, because that's what you wanted to do in your preoperative plan. It's not that you've done anything really different to the biology, because the biology would have got there eventually, and as you can see, it's healed quite quickly. But your construct wasn't durable enough to see it through. So, is that a non-union? Or it's a delayed union, but it delayed too long for your implant to keep it going. And so combine your implants. So, stability. Absolute. At the fracture site, you're trying to achieve load strain, and to do that, you need to preload it. And preloading is storing potential energy where you're getting compression at the fracture site to maintain stability. Relative stability is where the fracture site is not preloaded and you allow there's going to be some motion, but you're hoping that as the fracture matures, it will get to the point where the strain goes to a low enough level so that you can get ossification. Don't forget, you've got to think who it is, what it is, and where it is to configure the fracture fixation that you want. And that you're not just trying to achieve a healed bone necessarily, but the patient has got to be able to do what you regard as important for their long-term recovery. So for older patients, that's mobilization. So you can't just fix it and then rest it. You have to treat the whole patient. That is the end. Apart from one little slide, two little slides I'm going to show you. I want you to think about this. Because we're talking about preload, and I learned this just recently. So this is called bolt theory. So if you have that bolt in there, and we say we have 2 kilograms of compression on that bolt, and we put a 1 kilogram weight in the box underneath, what is now the tension in the bolt? So it was 2 kilograms of tension in it before we put the weight in there, and we put 1 in the box underneath. And bolt theory, if you look at it on engineering websites, will tell you that there is no change in the tension in the bolt. It remains at 2, or as near as damn it. And so if you put a configuration, and this applies mainly to, not across the fracture site, but putting the plate on the bone. If you use a compression screw on the bone, and you compress it, and you store energy in that bone, there is no load change on the screw unless you exceed that preload, so they don't fatigue. And that's why that's why the doors don't fall off eventually. It doesn't matter how often you open them. It's because of bolt theory. And I can explain it to somebody afterwards. But and I think it shows that our intuition about what we're doing with things isn't always right, because I had no idea. My intuition wouldn't have led me to believe that. I would have thought that you increase the load on it. But engineers will tell you that's not the case. Thank you.